Good afternoon, everyone, and welcome to the Community Mental Health, Drug and Alcohol Research Network's webinar, Unpacking the Annual Overdose Report with the Penington Institute. My name's Katie Sam, and I'm the project coordinator for CMHDARN. And I'll begin today by acknowledging the traditional custodians of the lands of which we're all variously meeting upon today. I'm working on the lands of the Gadigal and Wongal people of the Eora Nation, and I pay my respects to their elders past, present and emerging, and extend that respect to any First Nations people who are attending today. And I'd also like to recognise those with lived experience of mental health conditions and substance use, and the important contributions in informing policy and service reform, particularly through research and evaluation. So thank you very much for joining us today. I hope that everyone is able to take something away from the session. The Penington Institute champion a transparent and respectful approach to building and sharing knowledge to reduce drug-related harm, and their annual overdose report provides a comprehensive snapshot of the overdose crisis in the Australian context. And I thought it would be a great opportunity to have them share their insights relative to the importance of this data for the NGO and the community managed sectors. So before I hand over the reins to the wonderful Dr. Karen Gelb, I encourage you all to please use the chat and Q&A functions throughout the session. Dr. Gelb is happy to answer all of your burning questions. Please don't be shy. We're due to finish around 4 o'clock today, and this webinar is being recorded for you to access later if you're unable to stay for the whole event, and also to share with your respective networks. So I think that's all of the housekeeping done. So I'm now delighted to introduce our fantastic presenter, Dr. Karen Gelb. Dr. Gelb is the Manager for Research and Workforce Development at the Penington Institute, who holds expertise in a range of criminal justice and social issues. And for the past 9 years, Dr. Gelb has also been an industry expert lecturing at the University of Melbourne's Department of Criminology. So thank you very much for bringing your expertise to CMHDARN today, Dr. Gelb.
Thank you so much, Katie, for having me and the opportunity to speak with your network. I guess I'll go ahead and share my screen so we can get going here. So I'm going to do this, and I'm going to hit share. And there we go. And you should all be able to see what's on my screen now. So I'd like to start by acknowledging the traditional owners and custodians of the lands on which we're meeting. I am on Bunurong people land, the Bunurong people of the Kulin Nation in Victoria, and I'd like to pay my respects to their elders, past and present and emerging, and also acknowledge anyone here today from a First Nations background. And you'll see why that this is very important in the context of overdose. I'd also like to acknowledge the value of people with lived experience around mental health and AOD issues. Again, in the context of overdose, that sort of experience and knowledge that they can share with us is really, really important. Penington Institute, for those of you who haven't heard of us, we are a not-for-profit, non-partisan organisation. We focus on supporting evidence-based, cost-effective approaches to maximise community health and safety. And this is not just in relation to illicit drugs, it's also in relation to pharmaceutical medications and to alcohol. We're also the convener of International Overdose Awareness Day, or IOAD. Many of you may have heard of this. For those of you who have not, this is a global campaign to end overdose and remember without stigma people who have died, and acknowledge the grief of those who have been left behind. It is held on August 31st every year. If your organisation is interested in holding an event, please do get in touch with us, because we offer all sorts of support and resources to enable people around the world to hold an event for IOAD. Each year, we create the Annual Overdose Report. We've been doing this for about 8 years now. It has grown each year in terms of content. It is now approaching 250 pages, I believe. So there's an enormous amount of information in there. It looks at illicit drugs, it looks at pharmaceutical drugs, and now it looks at alcohol for the first time. We've included that this year. We've also started reporting on non-fatal overdoses, and we've done that to acknowledge that the harm of drug toxicity is not just around fatal overdose, but it's also the impact of non-fatal overdose as well. I'm going to run through some data from the most recent report. These are kind of sort of the key findings from last year's report. You'll see there that we've got that sort of top level figure of 2,231 drug-induced deaths in 2021. And I just want to point out that 2020, why 2021 for a 2023 report? The data are sourced from the ABS causes of death data collection. The ABS gets its data from coroners around the country. It takes a while sometimes for coroners to make their final determinations on the cause of death and when it's related to drugs, the nature of the drugs involved. So there's kind of a delay in that process. So the ABS begins by giving us preliminary data. The following year, it will then revise the data to add any new cases that have come in. And the year after that, it will finalize the data and we'll sort of draw a line under it and say, this is the final number. Now, that means that it's kind of a 3-year cycle. And when we release a report, so for instance, this is the 2023 report, the most recent data we have are for 2021. Nonetheless, it does allow us to look at trends over time. And what we're seeing is, again, and still over many, many years, that the vast majority of overdose deaths involve multiple types of drugs. So it's unusual for an overdose to be caused by a single drug type. What we've seen looking at the number of unintentional drug-induced deaths, that's the 1,675 unintentional deaths, the number of those deaths has increased over the last 20 years by 71%. And that's happened at a time that the national population has increased by 33%. So what we're seeing is that the increase in unintentional drug-induced deaths has outpaced the increase in the number of people in Australia. So in the past 20 years, 22 years since 2001, we've seen more than 37,000 drug-induced deaths. That's 37,000 since 2001. We also know that the number of unintentional drug-induced deaths overtook the road toll in 2014. That's almost 10 years ago now. And the gap between the road toll and the overdose toll continues to widen. And that's important because, as you would all know, we put a lot of time and energy and money into reducing Australia's road toll. We do not do the same in efforts to reduce Australia's overdose toll. We know that unintentional drug-induced deaths are not evenly distributed through the community. They are, 70% male, 70% of them involve men, so men are overrepresented in unintentional drug-induced deaths. We also know that there are more deaths in rural and regional settings compared with metropolitan settings. Part of that is perhaps due to the lower probability, I guess, of prompt, sophisticated medical intervention. It may partly be due to different patterns of drug use as well. We do see different types of drugs being used in some rural and regional settings compared with metropolitan settings. We also know that about 1/3 of unintentional drug-induced deaths in that 5-year period from 2017 to 2021 occurred among residents from the most disadvantaged parts of the community. But while you have overdose deaths seen more commonly in those areas, you will note that overdose is nonetheless found throughout the community in all parts of the socioeconomic strata, I guess. Indigenous Australians continue to be greatly overrepresented in unintentional drug-induced deaths. So this figure here is a rate per 100,000 population. And you can see that the top line there is represents Indigenous people who have overdosed, and then the bottom line is non-Indigenous. So there were 20 deaths per 100,000 population among Indigenous Australians in 2021, compared with 5.6 per 100,000 population among non-Indigenous Australians. So Indigenous Australians have an overdose rate more than 3 times that of non-Indigenous Australians. We also see there's a far more rapid increase over time in that rate for Indigenous Australians. So for Indigenous Australians from about 2009, you can see that dip there in the data, the overdose death rate increased from 9.5 to 20 deaths per 100,000 population, so it more than doubled. But over the whole period of that graph, you can see for non-Indigenous Australians, it's been very stable. And in fact, it's increased from 4.9 to 5.9 over that 20-year period. So you've got this significant increase for Indigenous Australians and a much more stable rate of overdose death for non-Indigenous Australians. I should point out here that the data that we have from the ABS on Indigenous status is not from every jurisdiction in Australia. It's only for New South Wales, Queensland, WA, South Australia, and the Northern Territory. So they're the only jurisdictions that have an appropriate level of Indigenous identification and enough deaths among Indigenous people for the ABS to be able to include these data in their analysis. This overrepresentation is found particularly for stimulants and opioids. So this is the rate of death. The dark blue line is Indigenous people. The light blue line is non-Indigenous people. You can see a very significant difference there for stimulants in particular. That's that second pair of columns. So in the 5 years to 2021, when you look at stimulants, there were 8.5 deaths per 100,000 Aboriginal people compared with 1.9 for non-Indigenous people. You can also see a large difference for opioids with a rate of 9.5 per 100,000 Aboriginal people compared with 3.6 for non-Indigenous people. So for those two types of drugs, the overrepresentation is particularly pronounced. Overall, though, we know that overdose death continues to be driven by pharmaceutical drugs. Almost half of all unintentional deaths involved opioids, and a third involved benzodiazepines. We also know that antidepressants, anticonvulsants, antipsychotics are involved in overdose death. So we've got a lot of pharmaceutical drugs involved. Now, I don't mean to demonize pharmaceutical opioids. I don't mean to criticize people who use and need opioid painkillers for chronic pain. This is what the data show, and what we are saying is it's important to be aware of the medication you're taking and the potential for danger with your medication. And with all medications, one needs to be aware of drug interactions. Looking specifically at opioids, You can see how the vast majority there are polydrug deaths, and in particular, opioids plus benzos and opioids plus other pharmaceuticals. So there's a real issue with this mix of medications, particularly the central nervous system depressant medications. We know that in the 5 years to 2021, pharmaceutical opioids on their own, just on their own, accounted for less than 8% of unintentional drug-induced deaths that involved pharmaceutical opioids. So more than 92% of these deaths occurred in the polydrug context. I will also point out, you were looking at a time series graph here. There's a vertical line there between 2019 and 2020. That's a function of the revision process that the ABS undertakes. So the data to the left of the line are finalized and set. The data to the right of the line are not yet finalized. So the 2020 data are revised and the 2021 data are preliminary. What that means is that the two data points to the right of the line will actually go up over time. As the ABS finalizes its data next year and the year after, these figures will go up. And we know from past years that we should expect about a 12% increase over the next 2 years. Looking specifically at changes in particular drug types over time in the last 20 years, you can see that stimulants and benzos have become more prominent in overdose death. Opioids are still up the top there, that's the dark blue line. But you can see with benzos that increasing, that upward slope of the line, indicating the increase in the proportion of unintentional deaths that involve benzos. Similarly, with the red line, you can see stimulants. If you go back to 2001, stimulants were detected in just 5% of unintentional deaths. But if you come to 2021, it's gone up from 5% to 28%. So there's been a big increase in the proportion of unintentional overdose deaths that involve stimulants. Similarly, benzos have increased from 17% of unintentional deaths to 33% in 2021. So their involvement in overdose death has increased substantially over time. When you look at the prevalence of some of the other drugs, antidepressants, for example, anticonvulsants, antipsychotics, it highlights that high comorbidity that we see between drug use and mental illness, which of course would be most pertinent, particularly pertinent for the people watching this webinar. When you look at intentional overdose death, so that is suicides, the most common drug types involved are benzos or opioids and antidepressants. And you can see a really clear demarcation here in those three being far more commonly involved in overdose death than the other types of medication. New South Wales, in fact, had the second highest number of drug-induced suicides. In 2021, there were 112. And I will note here that for a death to be classified as a suicide by the coroner, there needs to be a really clear indication that it is in fact a suicide. So something like a note that is left. So the count of intentional overdose death may actually be an undercount if there's no sort of clear sign that the death was intentional. We know that intentional overdose deaths are more common in regional and rural areas than metropolitan areas, that it has switched. You can see in around 2010, there was a switch from the regional and rural areas being having a lower rate of deaths, and then around 2012, it overtook the rate of intentional overdose death in capital cities. And the preliminary data show that the rate of drug-induced death outside of capital cities is increasing. So we know that in 2021, there were 1.9 intentional drug-induced deaths in rural and regional areas compared with 1.6 per 100,000 in the capital cities. This is a screenshot. I'm not expecting you to be able to read it, but this is a screenshot of one of the case studies from the report that we've put in. And this is sort of we put this in now at the start of each of our chapters. This is a case study of a woman who was classified as an intentional drug-induced death. And you can see if you sort of look down towards the end, it says toxicological analysis identified a fatal concentration of oxycodone and an elevated concentration of oxazepam in Margaret's blood. The toxicity of these drugs is greatly increased when taken together, resulting in death due to depression of the central nervous system. And there was also alcohol. So the polydrug nature of many deaths is illustrated here. So what do we know about New South Wales? This is probably of most interest to you, and we can look at some data from New South Wales. New South Wales had the second highest rate of unintentional overdose death in 2021. That dark blue line at the top, way at the top there, is WA. And New South Wales is the light blue line. In 2021, you've just pipped Victoria and just got more than Victoria. In 2017, New South Wales had a high of 605 deaths. In 2021, it looks like you've got 554 deaths. So fewer deaths down from the high in 2017, but remembering that that figure of 554 deaths in 2021 will increase once the data are revised and then finalised. Higher rates in New South Wales regional and rural areas than in Greater Sydney. That is pretty typical, largely seen around the country. There's that difference between the metropolitan and other areas. So in regional and rural New South Wales in 2021, the rate of death was 7.4 per 100,000 population. There were 218 deaths. In Greater Sydney, the rate was 6.2 deaths per 100,000 population. But of course, given the larger population, there were more actual deaths. There were 333. We can look at the drug type responsible for unintentional overdose deaths in the different areas. So if we look at Greater Sydney, you can see that we've got stimulants being the drug most commonly involved in unintentional drug-induced deaths, with a rate of 1.8 per 100,000 population. In rural and regional New South Wales, it's other pharmaceuticals that are most often involved. That's a pretty broad group. That excludes opioids, pharmaceutical opioids. It excludes benzos, but it does include the anticonvulsants, antidepressants, antipsychotics, sedatives, hypnotics, anesthetics. So there's a whole range of other pharmaceuticals there. But looking at New South Wales, it's the benzos and the other pharmaceuticals that have contributed most to overdose death in the past 5 years. So you can see you've got the number and rate there over a 5-year period for New South Wales by drug type. The rate and number are highest for benzos. The rate for all of these is slightly lower than the rate across Australia. So you can see benzos, other pharmaceuticals, and then the pharmaceutical opioids. We do have alcohol in there, which is interesting to look at because people tend not to think of alcohol when we're talking about drug overdose. But of course, we know that not only can alcohol be toxic on its own in large amounts, but certainly as a central nervous system depressant, when you combine it with other depressants, it can contribute to a fatal outcome. These are what we call heat maps. They are coloured according to the rate per 100,000 population of unintentional drug-induced deaths. So the darker areas have a higher rate of unintentional drug-induced death over that 5-year period. On the left, we have Sydney. On the right, we have all of New South Wales. So the one on the left kind of allows you to zoom in so you can see what's happening in the different parts of Sydney. And you can see simply by virtue of the colour, you can see the higher rate of unintentional drug-induced death outside of Sydney, and in fact, all the way over in those far western areas of New South Wales in particular. And I should say with those SA3 data, so a statistical area 3 is similar to a local government area. So if you're interested in looking at your local government area, we do have the data for those maps in the back of the report. This is some of the data from the 10 highest New South Wales SA3s, so the ones with the highest rate of unintentional overdose death. You can see the regions there. You've got the number and the population giving you the rate per 100,000. And you can see Broken Hill and the Far West. That's what you were seeing in those heat maps. We also have information on looking at the number of unintentional drug-induced deaths over time, over in 5-year periods. And the reason we do 5-year blocks here, of course, is because if you were to do it year on year at this level, at the SA3 level, you'd get too few deaths in given years to be able to report. So we do that in 5-year chunks. And you can see that there's been some really large increases. If you look, for example, at Port Macquarie there, more than 300% increase from 9 unintentional drug-induced deaths in the 2007 to 11 period to 38 in that final 5-year period. So that's an overview of the data. But what does it mean for you? What does it mean for people in this research network at the front line, doing work in this area, researching this area? How can you use these numbers, this evidence for your everyday practice? One of the things we do at the end of towards the end of each year after we've released the overdose report is we send out an evaluation survey and we ask people how they use the overdose report and how it's useful for them, how it's helpful for them. We start off by asking them who they are, what kind of group, how they would classify themselves. You can see here we have a lot of healthcare providers and drug treatment providers. We also have people who themselves have been affected by drug use or overdose. In the other category there, 18% in the other category, you can see on the right, we have educators, activists, politicians, students. So it's quite a wide range of people who use the report, which is great because it's great that people find from all areas, a lot of different areas find it useful. And how do they actually use it? Well, we like to think that the overdose report has become sort of the definitive reference source on overdose. And you can see here 3/4 of people do indeed say they use it as a reference source. About half of people say it informs their daily work or their advocacy efforts. It teaches them, it's professional development, service planning, engaging with clients. And this is really important, this issue of engaging with clients. And I'll show you a bit more about that on the next slide. But you can see on the right there, the other, how do people use Australia's Annual Overdose Report? It's educating the public on risks. educating nurses and pharmacists, particularly around opioids, developing plans and events, training packages. So people use it as a reference to know what's going on, but they also then use it to directly inform their work, which is fabulous for us. We ask them what actions they take after reading the report. And there's sharing or discussing it, presenting for other staff, myth busting, I think is a great way to be using it. Informing research or in speeches or talking with the media. I've highlighted a few here that I think are really valuable for us to know, and I think really valuable for you in the mental health and AOD field to know as well. One person said that they used the information in teaching medical students and anaesthetic and pain medicine trainees. So it's about trying to inform prescribers about, be aware of mixing drugs, be aware of this issue that, you need to look holistically at the medications that a person is taking, because we know that polydrug death is involved in about 3/4 of overdose deaths. The one on the right there developed an overdose action working group to review and implement what was relevant to our service. That's fantastic. That is a service getting together, using the data to say, well, what is it that, that is happening in our area? What does overdose look like in our area? And do we, are we addressing it appropriately? Are we doing what needs to be done? And that last one there is part of developing a peer education program aimed at increasing Aboriginal access to our services. Immediately included opioid overdose and naloxone into that package. So given the prominence of opioid overdose in overdose death, the importance of including discussion of opioids into training packages, and also including naloxone, the availability of naloxone. Of course, we now have the take-home naloxone program under the Commonwealth's recent rollout of that. In New South Wales, I understand that your take-home naloxone program is actually working really well, and that you're already onto your second stage of people being able to distribute naloxone. For those of you who aren't aware, naloxone is an opioid overdose reversal drug. It comes in a number of different formulations, the easiest of which is a nasal spray. People who are likely to witness an overdose can carry that with them and can administer it very simply to someone who appears to have overdosed. You can't hurt someone, you can't harm someone by giving them naloxone. And if you are interested in finding out more about that, or about having some training around what naloxone is and how it works and how you can get that into your clients' hands, please get in touch with us, because we do offer naloxone training as well. And finally, we ask people to agree, disagree with these three statements. And you can see we have a lot of people, the vast majority of people, strongly agreeing that the Annual Overdose Report has helped improve their knowledge of overdose, that it helps them to advocate around overdose, and that it helps to inform service provision at their organisation. So I would encourage each of you to, of course, go and download the report, have a close look through it, think about how you can use it in your own organisations, come back to us with any questions, come back to us with any training requests. It's a really, we think, a really valuable tool. So do feel free to get in touch. I've got the download link there, and I'm sure Katie can share that, send it around to the network, and also the contact details. So I'm going to stop my share at this point.
Thank you so much, Dr. Gelb. That was so interesting. I know that my brain jumps when I see the kind of graphs laid out and you see these dips or these peaks, and I immediately go, oh my God, what was happening in 2009 that caused that dip for First Nations deaths? What can we learn from that? And I guess I'm assuming that that's the hope of the Penington Institute, by kind of laying it out, that people will then do their own research and to then see, yeah, what was working then, or what was happening then that might have contributed to that. And
Yeah. And look, it fluctuates. So some of it is random fluctuation. But as policies change, as for example, codeine became upscheduled and became a lot more constrained, we have seen a decrease in codeine related overdoses. So you do see as prescribing patterns change, as policy and legislation change, you do see some changes in the data. Not necessarily a causal link. We can't determine that. I'm not saying that this definitely caused that, but it may very well have contributed to it.
Yeah, so interesting. And look, I'm going to ask Dr. Gelb a few questions, and I encourage the people online to please use the Q&A and the chat function to ask questions. Also, feel free to share what ideas you're starting to think about how you're going to use the report. There were some great examples, and I think that the working group in the service was really inspiring, and I think something that we should be advocating for more as well. And yeah, I think that it'll be interesting to see if it's got people's minds ticking. But I guess firstly is what's the biggest goal for the Penington Institute in doing this every year?
To draw attention to this ongoing crisis. And in our forward each year, the CEO every year says we need a national overdose prevention strategy. We have a crisis. We have had a crisis for many years now. We just don't get the attention. We know if you look at Australia's national drug strategy, we know that 70-odd% of the money around that strategy that's handed out by the government around that strategy goes to supply reduction. So law enforcement, border force, police, law enforcement. We know then that about 20 to 30% goes to treatment services. So that's demand reduction. Harm reduction, 2%. So things like needle and syringe programs, our safe injecting room, your safe injecting room, any harm reduction services get a measly 2% of the national drug strategy funding, because we put all of it into law enforcement. And we can see from these data that's not working. That's not doing anything to address the overdose crisis. So what we're trying to achieve is to sort of wave a flag in front of people and say, look at these numbers. And every one of these numbers is a person, is an individual. So it's not just, 2,000 odd people or 1,675 unintentional overdose. It's their families and their friends and their communities around them that multiplies the number of people who are harmed by overdose, enormously. And yet we're just not paying any attention to it. So we're trying to get people to pay attention, trying to get funders, government to pay attention. At the same time, we're trying to provide information for the community. So, it's part of a harm reduction strategy. This is what you need to know about overdose, right? You need to be aware that there are risks, whether it's illicit drugs or prescription drugs. If you're putting something into your body, there's a risk involved. So make sure that you're talking to doctors, make sure you're talking to harm reduction workers, make sure you're talking to friends, make sure that, you know, you're if you're going to be using either prescription medication or illicit drugs, do it with an awareness that all of these things potentially can be risky. We see in the back of the report, we've got information on the non-fatal overdoses, and we've taken that this year from the different poison centres that are around the country, their annual reports that get put out. And with our advisory group, we were talking about the best way to present, you know, the best source of non-fatal overdose data, because it's extremely tricky to find data, you know, to get reliable data for that. And one of the emergency room and poison centres here in Victoria, the single most common, by far, the single most common drug that causes people to come into hospital and causes them to call the poison centre is paracetamol. Right? It's just paracetamol. And yet it's clearly got enough of a level of toxicity that people are having problems with it and having to go to hospital and having to call the poison centre. So we don't think of that. You know, when we're thinking about overdose, when we're thinking about drugs, we've got this very stereotypical picture in our mind. And part of what the report does is to say, look, it's not, you know, only what you think. It's not only what the tabloid newspapers are presenting to you. It's everyday people taking their medications, probably taking their medications as prescribed. There's just been, you know, there's been some confusion, there's been some lack of communication. Something has gone wrong somewhere along the line, and the toxicity has built up, and it's led to either a non-fatal or a fatal overdose. So that's a lot. We're trying to do a lot of things with this report, but it's really about getting the data, getting the information, getting the messages out there.
And so what do you think are the key points, I guess, of systemic change or even more localized change, like within kind of frontline, that you think needs to happen to help bring these numbers down and address the crisis?
Well, having more funding for the harm reduction services allows people who do use drugs or do use medications to be better informed. It allows training for doctors, nurses, pharmacists to make sure that they're asking the right questions. It's not about necessarily changing prescribing practices. One would assume that doctors and all prescribers are doing the right thing and doing their best to prescribe appropriately. But it's about encouraging them to just be aware of the risks so they can have those conversations. So there's a lot, you know, and all this would go into an overdose prevention strategy. Community awareness campaigns, you know, helping people understand what they should be asking their doctors. Right, it's one thing to rely on doctors, but we want the patients to be informed as well. And we want the patients to be able to say, you know, I'm actually also taking this other medication from this other doctor. Is it okay to mix the two? So it's about informing the consumers as well.
Absolutely. And I assume that, yeah, particularly when people are on like opioid replacement treatments and stuff, and then are on antidepressants, and so knowing and having kind of reminders as well of the potential impact if there's a slip and things like that as well, that it's not just a one-off conversation as well, I assume, with polydrug use, that it is an ongoing conversation between workers and service users.
Yeah,
and
absolutely.
What I found interesting was hearing that this was the first year that you guys have included the case scenarios at the beginning of each chapters. And I guess I'm curious about the decision to do that and whether you've had any feedback about that as well?
We have had a little bit of feedback saying that people have thought it was valuable. The intention there, it's a very data heavy report. Clearly, it's just all numbers. It's numbers, graphs, tables. It's just lots of data. We want to remind people of the individuals behind those numbers. That's really the key thing with the case study is to try and humanize the report. It's one thing to present numbers, and it's one thing to, I guess, try and engage with people on that intellectual level. So intellectually, here are the numbers, this is what you need to know, But it's another thing entirely to engage people, to engage readers on a more emotional sort of level. And to do that, you really need to draw attention to the fact that every one of these numbers is a person. And this person has a whole story behind them. So these case studies are real. The name has been changed, obviously, but they have been drawn from publicly available coroner court cases that are available on their websites. So, each of these was a real person, and each of these has ended up in our data. So that was the intention there, and to try and get people to connect emotionally as well as intellectually.
Yeah, and I think that having that, I guess the double-edged sword, I guess, I think particularly heading into our drug summit in New South Wales, which is coming this year, I think having both of those kinds of evidence is really important. And I think that's where it's really important to have people with lived experience in the room, whatever this drug summit ends up looking like. As well as then having this very clear data. And I think you and I had a discussion last week saying that you kind of hope that everyone would have a copy of it before they they headed into this summit to be able.
I'm hoping that everyone is going to walk in and they're going to have a printed, well, it doesn't have to be printed because that would be a waste of paper, but would have their tablet with a copy of this report, and that the discussion at the drug summit, as you say, whenever it is, whatever it may look like, is informed by the data. The data are there. The New South Wales data are there. We know what is going on. Make decisions based on that, not based on, whether you're going to be re-elected.
I definitely agree with that statement. And I saw there was a question in the chat from Anna about whether cannabis on its own contributes to deaths, or whether it's more in the polydrug use. Whether on top of that, your heads are aware of that?
Yeah, cannabis, we get this question all the time. It's probably the most common question we get out of the report because it's quite confronting. Cannabis. Why are people, why are there overdose deaths associated with cannabis? A couple of things about that. The vast majority of the deaths that involve cannabis are polydrug deaths. So remember, this is not that one particular drug type is causing an overdose. The drug type data show where a drug was found in the tox screening that the coroner did. So the person has died, and there's 1, 2, 3, 4, 5 drugs there. So we don't have an assessment of which of those in particular caused the death, but then you get the comments like you saw in that case study about the mix of drugs. There were a number, and there are each year a very small number of deaths that involve cannabinoids on their own. So over the past 8-9 years, there are about a dozen deaths that involve only cannabinoids. Now, here I'm saying cannabinoids. I'm not saying cannabis, because every one of those single drug type deaths involve a synthetic cannabinoid receptor agonist, right? So it's a synthetic product that mimics the effect of cannabis to act on the cannabinoid receptors in the brain. It is not cannabis. Cannabis is, you know, the phytocannabinoid, the natural plant cannabinoid. It's not that. The ones that are only that are just the cannabinoid on their own, causing death, very, very few of them, only about a dozen. All of them are the synthetic cannabinoid receptor agonist. So it's a really common question. Thank you for asking. It gives me an opportunity, Anna, to clarify.
Yeah, thank you, Anna, for asking. What are the biggest challenges in making the report, doing it each year?
It takes forever.
Yeah, I can imagine.
We get a very large data extract. The report has, I don't even remember the number, 90 odd figures. It's got dozens and dozens of tables. Every figure has the underlying data in an appendix. So if you see a figure that you're really interested in, you can actually go to the appendix and you can look at the data that underlie that figure. So we spend several months just manipulating, you know, creating the graphs and tables. And then of course there's the whole layout design sort of process. But that it takes a long time, and that's a real challenge for us. We do work closely with the ABS. I'll give them a plug. They've been fantastic for us in helping us to understand the data, helping to give us additional, you know, when we've asked another question, do we know anything about this or that? They're able to go and find out for us. But I will point out that we're completely unfunded. This is not a funded product. This is something that we do out of our ongoing, you know, staffing resources, really. But it's enough of a priority for us that we are willing to spend, you know, the time, effort, resources in putting it together.
And you said that it's kind of growing each year as well.
Yeah.
So I'm curious about that. Like, how is it growing? So I assume that, I don't know, because you're saying it's unfunded, it's probably still working on the same amount of resources, but is it external resources in terms of the information that's available that's helping grow?
No, we just keep pouring more effort into it.
Yeah.
And we ask in our evaluation, we actually ask, what else would you like to see in the report? So a couple of years ago, we had a few people say, you know, it'd be really interesting to bring in sort of broader context, broader information on drug trends. And we thought that's a fantastic idea. And so we looked at it a couple of years ago, and then last year we ended up putting it in. We included data on from the ACIC, the Australian Criminal Intelligence Commission, their wastewater analysis data. We included that to show what was going on sort of in the background. So it's things like that where we try to bring in other research, other sources of data. We try to expand. There's a lot of data that we get in the extract, like there's a huge amount of data, and we don't use all of it. So each year we try and say, well, what else can we do? What else can we look at to expand this? Last year, for the first time, we included the data underlying the heat maps. We hadn't done that before. We had to pull that all together and include that. The alcohol chapter was brand new last year. That had not been the focus before. A couple of years ago, for the first time, we did the non-fatals. So we're always looking to expand things. We're always looking to, I guess, provide more information and provide a bit more analysis to the point that we can, given that, you know, we're constrained, we're limited by the fact that we're not collecting the data. It's the data from the ABS causes of death collection.
Well, we're kind of coming to the end, and so I want to ask you to kind of wrap it all up. You've got probably a mix here of academics, people that are researchers, people that are working in the front line in NGOs and CMOs, people kind of in government as well, in New South Wales Health. What do you think people in the mental health and AOD sector needs to be their biggest takeaway from this report, either in advocacy or in kind of working directly with people?
In the advocacy space, I think it's important to use the data with any advocacy to show the scale of the crisis.
Mm-hmm.
It needs attention. You only need that one number, 1,675 unintentional drug use deaths, right? It's a crisis. 37,000 people over 20 years. If it were any other cohort, if it were anything else, government would be all over it. Mm-hmm. Use it for advocacy. In terms of service provision, understand your cohort, right? Use the data to understand where your cohort fits in and to think about how you can educate, inform, work with your cohort to prevent them from ending up one of these statistics. And for any funders out there, if there's any government funders out there, please get in touch. It's a very important report. Overdose is a very important issue and it needs attention. So yes, please get in touch with us.
Thank you so much, Dr. Gelb. Thank you to the Penington Institute and to everyone who's participated today. It's been so informative and so interesting, and I think incredibly timely, seeing as where New South Wales is at coming up. There's lots of reform in this space, hopefully. There's a lot of discussion, and I think, and particularly drawing on just continual stigma and discrimination as well, and reforms in that space too. I think that that's really important, and what I think an underlying message of what this report highlights too. So I think we're going to tee it up there for today, but the webinar recording will be available on the CMHDARN website in a few days. A little survey will pop up after I finish the webinar. Please give us your thoughts. It's really important to keep CMHDARN going so that I know what's working, what isn't working. And just want to thank you for your continual support, and thank Dr. Gelb so much again for your time and expertise. It's been really, really wonderful.
And thanks for the opportunity to talk.
No worries. Thank you and have a great afternoon.